Morning.
Good morning, Dr.
Mhm. Okay. So this is an 8-week-old who has comes into the emergency room and has poor function. And this is the tracing. So what is a differential diagnosis of what we're seeing here? Why don't we ask Dr. Bestakova what she thinks?
Good, good morning, Dr. Pass. So looking at this EKG, it's a 8-week-old with poor function, the ED. Um, so first looking at the EKG, uh, at the strip, looking at it, looks like the rate is about, uh, it's pretty regular, and it looks to be about, mm, 200 or so. And then I'm looking at if I see it's pretty fast for an 8-week-old. And sorry, I missed that earlier with what you were saying earlier. If there's poor function, if we did an echo before this, or if the patient was just appeared to be
Okay. Why don't we just
hemodynamically.
say, yeah, why don't we just say it doesn't look great hemodynamically? That's
Okay.
probably what a
Um,
smarter question.
and then and so it's a for 8-week-old is tachycardic, not looking great. And you have the CKG.
What do you think
Um,
about the rhythm?
the rhythm, trying to see if it's sinus rhythm or not. It doesn't look like it's sinus.
I agree with you.
You know,
Why does it not look like sinus? I agree with you, but why?
you do see what look like P waves, but they don't look like normal P waves. Looking at V1,
Hmm.
looks like the PR interval Um, looks a bit prolonged, and also the P waves just don't look normal.
Hmm.
So I think it looks like
What about the
EAT
P wave axis?
and the P wave axis. So we are positive in one, and in AVF it also is
Hmm.
positive.
Okay.
So we have a normal P wave axis for an 8-week-old.
Hmm.
And then
Well, the P wave axis is normal in
yeah,
all human
I
beings
know.
at all parts of their lives. So, okay, so I agree with you 100%. And so what do you think this could be? I think you started saying it and I cut you off, so I apologize.
I think this looks like it could be EAT, um, or it could be sinus tachycardia if the P wave axis is
Well, is
normal.
it
But
sinus tach or not? You just made an argument, a different argument. So,
yeah, no, I'm gonna go with it. It looks like EAT
hmm.
potentially.
Okay, I agree. It could be ectopic atrial tachycardia. Very strange looking P wave. Right? I mean, this is not the, although it is, I agree with you, it's upright in 1.5. It doesn't look, certainly not a normal appearing P wave. The PR interval is on the long side for an 8-week-old. What would the normal PR be in someone who's 8 weeks old?
Mm, a normal PR interval for an 8-week-old would be about uh, at like 120 or so.
Yeah, or even less, right? And this is certainly much more than that, right? This is a
Mm-hmm.
PR of like 160 or 170. Okay, so I would agree, and the poor function would go along with that. Um, Anything else in the differential of this, assuming it's, so we said sinus, but it seems unlikely this is sinus given the morphology of the P wave.
And then,
Very strange looking. What else could it be?
just it could also be PJRT as
Yeah,
well.
could be PJRT. And what would be consistent with that diagnosis?
I think that uh the PR interval,
Is it the
um
PR or the RP?
the RP is prolonged.
Yeah, this is a fairly long interval between the QRS and the next P wave, right? It's probably about 160 milliseconds. Normally, what if someone were in orthodromic reentry via a usual or a normal accessory pathway, what do we normally say the R to P interval is greater than?
70.
Yeah, 70 milliseconds. That's exactly right. And so now that doesn't mean it has to be 70. It could be 120, but to be 160 milliseconds where the P wave is actually visible between the QRSs, it's possible that could be PJRT as well. Any possible ways? So I agree with you that this is, and it's probably not atrial flutter, right? Because what is the atrial rate usually in small infants in atrial flutter?
It'd be like 300.
Or even 4 or 500. It's
Mm-hmm.
usually very, very fast. So this would be a very unusual atrial flutter for an 8-week-old. So it's not atrial flutter. So you have this sort of differential diagnosis of EAT, which I agree is probably number one on the list, and PJRT, which is number two, but it could be. Is there any maneuver you could do that might help you figure, excuse me, figure this out?
You
Which
could
of
try
those two it is? Sorry.
vagal maneuvers.
Okay, what would a vagal maneuver do? If it were EAT, what would you expect would happen if you were able to stimulate the vagal nerve, let's say by putting ice on the child's face or knee chest position or something like that?
If it was EAT, vagal maneuvers wouldn't really work.
Well, what would happen, do you think? What could happen? You're right. I agree with you. It wouldn't terminate the arrhythmia usually.
Mm, I'm not sure. Um,
Well, it could cause heart block
oh,
transiently, right?
yeah.
And the block is so potentially the atrial tachycardia would continue while in the setting of block
Mm,
transiently, which is why you would want to run the electrocardiogram rhythm strip while you're doing that maneuver, because of course a vagal maneuver is usually transient, usually 3 to 5 seconds. What would happen if this were PJRT and you did a vagal maneuver?
um, would it could potentially abort the arrhythmia?
Yeah, it could terminate the arrhythmia at least transiently. And that's the important point. So in both of these, whether it's EAT or PJRT, in PJRT or EAT, so in EAT, we would expect that the rhythm would persist despite a vagal maneuver. Although, unfortunately, as is the case in everything in medicine, there are exceptions, and some EATs will transiently terminate with a vagal maneuver. But most of the time, if you did a vagal maneuver, or alternatively, if you gave adenosine, you should normally see the EAT persist. It's not a guarantee. Some EATs are adenosine sensitive. And PJRT, again, you would see termination, but because it's PJRT, it's very common that the tachycardia will resume almost immediately after the pause of breaking of tachycardia. That's why it got the misnomer of permanent form of junctional reciprocating tachycardia. Permanent was meant to imply that it seemed like the patients never came out of the arrhythmia. And we've talked about why PJRT patients go into tachycardia so often. And both EAT and PJRT can cause dysfunction and are both common causes of tachycardia-induced cardiomyopathy. And both, thankfully, if treated, we can usually see resolution in the dysfunction. One of the very few causes of myocardial dysfunction that is reversible. Okay. Any questions about this? Great. Good job there, Christina. Okay. Changing topics entirely. This is a patient who had a transcatheter ASD closure, and they're coming back into the office 10 days afterwards. So the question I pose to you is, what is it that we're seeing here, and how would you manage this? I should also say the ASD device is in good position and does not appear to be any residual ASD or valvular complications at all. So why don't we ask Dr. Opsikov what he thinks?
Good morning. So the first thing, I wish I had calipers, but and how old is this patient again?
Why don't we say 4-year-old?
4-year-old. Okay, so the rate is bradycardic. Looks like it's a rate of 60. And then would love to calibrate, see
Yeah.
P waves that look like they're almost regular, and then QRS.
I'll tell you for the sake of
complexes.
conversation that the P waves are on time,
Okay.
as are the QRSs.
Okay, so then in that case, this looks like third-degree heart block to be a complete heart block.
Right. So does that ever happen, Vlad? I mean, is this why would this happen with an ASD closure?
It would make me worried that the discs of the device could be somehow impinging on the AV node or the Pittsburgh system. But
So what are the borders of the AV node, Vlad? Where is it? What triangle is it located?
Right, the triangle of Koch. So it's the coronary sinus, the tendon of Totoro, and then it's the it's the
Got two of them. Give you,
rib.
give
Is
you
it the rib?
65%.
Is it the rib of the tricuspid?
It's the anterior leaflet of the tricuspid valve.
Yeah.
Okay, so you could easily imagine, right, that in the setting of a large ASD device, that there could be compression on that area. This is one of the risks of putting large devices in small patients, or even putting a large device in a large patient. Then you can get heart block. Okay, so you're in the office. You've been very excited with yourself because for the last week you've been telling people how you closed this 32 millimeter gigantic ASD. Device looked great. Patient was fine overnight. And you've been pleased with yourself. And then you come into clinic a week later or 10 days later, and this is the electrocardiogram. Patient tells you they feel fine, by the way. So what would you do about this? What are the options, I should say?
I think I would want to take a look at the device to make sure that it hasn't migrated or moved or eroded
That's a
into
great
anything.
idea. That's a great
So
idea.
I'd probably do an echo.
So you do the echo, and the echo folks tell you, to the best of their knowledge, it looks okay. They tell you that the discs are very, very close to the AV valves, but they don't believe it's causing any problem. There's no new MR or TR or anything like that. So it seems like you got away without causing any structural problems. And the ASD is closed. And to the best of their ability to know, it looks like it's in the same place. And there's no effusion around the heart, which of course you'd want to know, because anytime you have a device that's so large that it could cause this, you'd want to make sure it's not eroding or anything like that. But you have no evidence for that at all. So what are your options now?
I don't know. I'm kind of stuck. Part of me, I don't know what the natural history is of post-procedural heart block in ASD. I don't know if this is something that could be a transient phenomenon, but I'm reassured that the patient is asymptomatic. I would probably want to. I think the question I'm not sure about is whether or not to take them straight for removal, or maybe admit, monitor on telemetry, maybe do a workup just to ensure that we're not missing any other etiologies of heart block if this kid just happened to have poor luck.
Okay.
And then
Not
maybe have
unreasonable.
and then maybe have after maybe a day or two or few of monitoring and seeing if this goes away or not, then deciding whether or not this patient would need the device removed if it's not in good position or a pacemaker put in.
Any other therapies you might want to try? I agree with everything you said. It's not unreasonable at all.
Could you do a course of steroids, maybe like a post-inflammatory if there is some swelling in that area from the new device?
Yeah, I mean, I think I would because what's odd about this case is, right, a patient has their ASD closed. As you know, we admit everybody overnight following ASD closure, and we would certainly not send somebody home with this finding. And so presumably they went home in sinus rhythm with normal AV conduction, and then you see this. So this would suggest to me that there has been some inflammatory process occurring that was not, that maybe progressed from the time of implantation till now. So I don't think there's any harm in trying the steroid. We know that in the setting of surgical heart block, there's no evidence that steroids are of any benefit. In fact, there might be some downside to it for other reasons. So that's the reason we almost, every year or two, somebody says, "Oh, do you want to try steroids in a post-op patient?" The answer should almost always be no, because there really isn't any evidence that it does anything positive. If you want to use steroids for some other reason, that's a whole other story. But in an ASD closure where there was normal conduction and then it became block, it would not be unreasonable to consider a course of steroids. Certainly with ablations, there's a lot of anecdotal evidence that if you leave the cath lab in sinus rhythm with normal PR and then you have some degree of heart block observed later, that steroids can reduce the inflammatory response to the RF applications, and you can recover conduction. And I myself had that early in my career. I had a patient with AV nodal reentry who did not have any block in the post-op period. At that time, we used to actually admit everybody post-ablation overnight. So we had 24 hours of telemetry with normal PR, normal conduction, and came into the clinic and they were in Mobitz 2 block. About a week and a half later, I was obviously very upset about this. We admitted the patient, put them on steroids, and it recovered. I don't know, now some might say that it wouldn't be unreasonable. Now, if you took the ASD device out, there is no guarantee that the conduction will recover. It seems likely that it would, but you don't really know. So some might say that a pacemaker is not as bad as an open heart surgery, and that with the open heart surgery, you might end up with a pacemaker anyways. So that's another way of thinking about this. I don't know if I would agree with that. I think almost everybody would try to take out the device if the conduction problems persisted at some point and try to just close the ASD. But the patient might still end up with a pacemaker anyways, but I think we would always want it. We hate to be the cause of blocking somebody, and if there's a chance that it can be recovered, I think we would all favor taking out the device if medical management briefly was unsuccessful. So I agree with all that you had to say on this, Vlad. Does anybody have any questions or thoughts about this?
I have a quick question. When you do go out and take out the device, what are the outcomes usually? Do you see recovery rather quickly? Do you ever see residual AV block just because damage had been done, or does it usually get better within
It's
a
a
few
good
days?
question. It's a good question, Ivana. And the reality is that there's not enough of these cases to draw a conclusion. I don't know if there's a paper on this. If there is, you can be certain it's extremely small numbers. So I don't think anybody knows. I think it would make sense that most of the time the conduction would recover. But another aspect of it is how long did it happen? In other words, if you bring the patient in at 10 days, give them a day or two of steroids, things don't improve, and you take out the device, well, the patient's only had 10 or 12 days of whatever this injury is that's causing this. If somebody comes back 6 or 8 weeks later and has this type of conduction problem, I would think that probably the injury would be more permanent because by then you should start having scarification. So I'm not sure if removing the device would make a lot of sense. It's one of the many reasons why we always want to see these patients, 1 to 2 weeks at most following the procedure, because A lot of the more serious complications occur in the first week, like erosions or embolization or heart block. I once had a patient in which I put a large ASD device in them. It was in good position, but the patient immediately went into first-degree heart block. And the question was, should we leave it with first-degree block or should we take it out? And this was very, very early in the Amplatzer ASD experience. It was probably like my fourth case. And at that time, the device had only been approved like literally 6 months. And Dr. Hijazi was going all over the country and showing people how to put the device in. And he had been at our center a few months earlier. So actually, with the device attached to the delivery cable, I called Ziad and asked him what he would do. And his recommendation was to leave the device in place and observe the patient. And if the heart block persisted or if the heart block worsened, that he would then take it out. But if it remained at first degree, he would favor leaving it, feeling that first degree heart block was a price worth paying to avoid open heart surgery. And so I took his advice, and that's exactly what happened. Was the patient ended up with first degree block and never progressed. Now, is that going to progress later in life? I don't know. Maybe, because as you know, all of our conduction gets worse as we get older anyways. And so if you sort of start your life with an injury there, is it going to be worse later? I don't know. It's one of the things I've often wondered about with AVNRT ablations. We leave the lab with normal conduction, but we have put a little scar in there. Is that potentially a nidus for a problem 40 or 50 years down the road? I don't think so, but we don't really know. So I don't know the answer to your question, Ivana. But I think that certainly if we took out the device and the conduction block was still there, I think we would treat it like a post-op heart block patient and give the patient 8 to 10 days of observation, assuming the patient was stable, on the hope that it would recover.
Thank you.
Thanks. All right. This is a patient who has intermittent 2-to-1 block. And this is an EP study, and the patient is being paced. And because there's no lines on this tracing, it's impossible to know what they're being paced at. But I'll tell you, it's cycle length 500 or rate of 120 beats per minute. So what is happening here in this 2-to-1 block? What is the mechanism for this 2-to-1 block? Why don't we ask our outgoing senior fellow, Dr. Kylas, what she thinks? This could be the last time I ever ask Dr. Kylas a question in EP.
All right. Good morning, Dr. Pass.
Okay.
Just so the leads that I'm looking at, because they're not
Right.
labeled, is that
Yeah, this is a little bit of a tricky
hiss?
question, isn't it? It's all EKG leads,
Uh-huh.
and then a hiss. I'm sorry, this is a crappy question, but the point isn't crappy, but the presentation lacks a lot. And so, yeah, so this is an atrial pacing spike,
Okay.
AHV, AHV, and this is the surface electrocardiogram. So a bit of a strange tracing. So you were right. That was a perfect question. It shows you've been listening the last 3 years, because the first thing I always say is look at the legend, but there's no legend.
Right.
All right.
Okay, so I see AHV,
Mhm.
and then I think, is that the HV interval you're giving me at 69 milliseconds?
Yes.
Okay. And then, so then the second one, it looks like there's AH, but then no V.
Mm-hmm.
And then the third one, it's AHV again.
Yep.
So,
I'm on the phone. I'm in the middle of a meeting. Is that okay? Is everything okay?
The contractors are here for your office.
Okay. It's going to be a few moments. Go ahead, please.
okay. So this is probably some sort of Mobitz type 2 block.
Right. So
It's
normally, yes, that's right. That's exactly right, Maya. Why do you say that?
because we have kind of like this intermittent drop of the V. However, I don't
So
know if I
where's the
can.
block? Where is the block?
So The heart block, it's above the level of the His, like at the level of the AV node, I think.
No, no. If so, we're conducting, we have AHV, and then we have AH. What's a normal HV interval, first of all? Is
Um,
69 normal?
I think that's a little long.
It is. A normal is about 30 to 50. So this is long. And then we see a His, a Novi. So where is the block? Is it below the level of the His or above the level?
Oh, I guess it would be below the level of the His.
Right, because we see A to, so remember that the AH interval is our surrogate for AV nodal conduction. We've talked about how you can't record the AV node in an EP study, so you can only record the low atrium or the high right atrium next to the anterior leaflet of the tricuspid valve and the His. By the way, I think I said anterior leaflet of the tricuspid valve. It's actually the septal leaflet, which is part of the triangle of Koch. Correction, sorry. But the HV is infrahisian, right? So, and you were right. So you called it Mobitz 2, and Mobitz 2 is usually represents what kind of block? Infrahisian or suprahisian?
I thought Mobitz 2 is usually suprahisian,
No,
but
it's
I could be
infra.
wrong.
It's
Okay.
infra. So Mobitz 2 is below the level of the His. It's a higher degree of heart block, right? Hence why it's Mobitz 2 rather than 1. Now, Mobitz 1 can also be infrahisian. We showed an example of that last week where we had prolongation in the HV interval. But most of the time when someone has Mobitz 1 block, we believe it's prolongation in the AV node followed by block. This is actually 2-to-1 block with infrahisian. Now, we've talked about, reason I wanted to show this is that, we often say there's three types of second degree heart block. The first is Mobitz 1 and the second is Mobitz 2. And the third we just say is 2-to-1. So, and the reason we say 2-to-1 is because it's often impossible on a surface electrocardiogram to tell whether 2-to-1 is from block in the node or block in the His Purkinje system. In this case, we actually have a His catheter, and so we can actually say that this 2-to-1 block is a form of Mobitz 2, which is what you said, Maya, just sort of fleshing it out. So this is actually Mobitz 2 block, or second degree, high grade second degree heart block. And so you wouldn't have to call this, you could call it 2-to-1, but you can also say that it's Mobitz 2 block, whereas normally we would just, if we just had like a Zio patch or a Holter monitor, and we saw, a 2-to-1 block, we would just call it 2-to-1, understanding that that's a form of second degree, but also understanding that we can't often on a surface electrocardiogram state whether it's at the level of the AV node or the His Purkinje. In this case, because we have a His catheter in place, it's at the level of the His Purkinje. At the beginning of my career, sometimes when we would have a post-op heart block patient, people would say, should we do an EP study to figure out where the block is? And the answer is no, we should not, because we know that in postoperative heart block, if it's above the level of the His, it's going to recover in the vast majority of cases. And if it's below the level of the His, it still could recover, but the chances are lower. And almost always, when it comes to surgical injury causing heart block, it's infrahisian. So this is an example of infrahisian Mobitz 2 block. So you got it right, but just have to remember, Mobitz 2 is usually a lower level of block or a higher grade of heart block. Any questions about that? I'm sorry, this is kind of a crappy question with no legend, but again, surface and His. Okay. All right, I think with that, we'll stop for today. I guess is this our last conference with our senior most fellows? Dr. Marshall, Dr. Capon, Dr. Kylas, is that right? I think that might be.
Yes,
So,
it is.
Well, I've been honored to teach you guys a little bit of EP the last 3 years. You all know so much now, and I'm proud of all three of you, as I am of all of you. So, of course, we've talked already, but I I'm just excited to see all the great things you guys are going to do, because I'm quite certain that's going to be the future. So thank you all very much, and have a wonderful day, everybody.
Thank you, Dr.
Thank you.
Thank you.
Bye.
Bye-bye now.